how do we know what's safe? How do we know what's legal?
We just don't know safety profiles for most of these things. I talk more people out of doing peptides than I put people on peptides.
If you start taking testosterone, that you can't stop taking testosterone. Is that true?
People I've talked to say they see it in about 10% of men. I saw a guy who was 30 with a stroke because he went to one of those TRT clinics. They didn't check labs afterwards.
All right, bingo, bango.
So listen, I think everyone coming on, this Dr. Richard Harris interview was interesting because he gave a lot of good information. If you're thinking about hormones, you're thinking about peptides, I think he was able to break down some myths for us on a lot of these things, and I would say a different approach, right, Ben?
You know, one thing we didn't focus on in the episode all that much, but is probably what makes him so outstanding, being a pharmacist and a clinician. I mean, those are like as a surgeon, whatever. I know how meds work. I know their mechanism of actions, but the pharmacy is complicated. That's why it's its own field. So I think that's why he's so good at what he does and how he has just really good insights into the. You know, he had really good recommendations. It was. I learned a lot.
I thought so too. And I think for whether you're a man or you're a woman, I think you got to listen to this episode because there's a lot of information about GLP-1s out there.
Peptides, I think.
A lot of information about peptides. And I thought a couple of things that he said, which I thought was super interesting, which a lot of people don't talk about is, hey, he feels like peptides should be more short term. And I did catch that a lot.
I mean, because, this is the thing. I don't want to say real clinicians, but like real surgeons, real clinicians are going to be slow adopters to this kind of stuff. We're going to have tight recommendations because it's all about the safety profile. Like, okay, if it makes you stronger, but you die in 10 years, that's, you're losing on that end. So it was, he had really good insights. Yeah.
I thought it was great. So listen, I think everyone, you're going to enjoy this episode. Make sure you're hanging around and you're checking it out.
Yeah, Dr. Richard Harris. What was Nimbus, right? Nimbus.com. I mean,
Nimbus
great.
Healthcare.
Cool thing.
Nimbus
Check them out
Healthcare.
first. I loved it. It was awesome.
Yeah. Welcome, Dr. Richard Harris, to the More You podcast. We are super pumped on having you here. We got so much to talk to you about and to get into, but welcome to the pod.
Thanks for having me, guys. I'm looking forward to our conversation.
Richard, where are you out of today?
Houston.
Great. Is it hot right now? It's got to be hot in Houston right now.
It's so hot our dog doesn't even want to go outside right now. That's how bad it is.
All right, so that we know. I'm in Toronto, and it was like in the 60s today.
I'm so jealous.
Yeah, a little dry.
So jealous of you. We're so once we get to about mid-October, man, we start getting really jealous of you. Anyway, Dr. Richard Harris from Nimbus Healthcare. This is an exciting podcast for us because there is so much going on in the world of longevity. Mm-hmm. And there, I think, is, yes, a lot of excitement. Yes, a lot of interest. Probably a ton of misinformation out there at the same time. And we're hoping that Dr. Richard Harris is going to be able to help us with that and actually be able to, I think, maybe myth bust some things that are out there as well. But why don't we start out, Richard, which I think maybe telling everybody a little bit about Nimbus.
Yeah, sure. So Nimbus Healthcare came out of my experience in telehealth and personal medicine, and then my partner owned a compounding pharmacy in Austin. And so we decided to expand our services really to create a personalized medicine company for the masses. And that was our goal. We're both clinicians. So we wanted to do it in a way that could reach the most amount of people, but do so in a way that was safe and responsible. And that's what we've done over the last 5 years. We're in 30-something states, have serviced thousands of patients across weight loss and hair restoration, peptides, hormonal therapies, supplements, you name it. So we're just getting started. We're growing, and it's been a really, really fun journey.
And so much going on in this space right now.
Yeah, it's hot right now.
And it seems like things are moving at like lightning fast right now. You guys are obviously, hormones are a big piece of what you guys are doing. I've also, just going through the site, understanding that you guys are doing GLP-1s and these types of things. I get for just first to start out with, you have these offerings. I think a lot of people out there are desperate for these services. And because of that, it's getting a little bit dangerous, I think, because People are trying to grab at anything and trying anything. What do you guys do from a method perspective of getting people the right kind of care that's really designed for them?
So I'll start off by saying this. I talk more people out of doing peptides than I put people on peptides. Right. Okay. And so what other group out there is doing that? Right. Most of the groups are like, here's a peptide for you. Here's a peptide for you. Peptides for everybody. Here's a stack of 10 peptides. Right. And that would help our bottom line for sure. Our revenue would increase if I did that. But I'm a clinician. So I'm not going to do that. I'm not going to put you on something that I think is not going to be beneficial for you or help your goals or outcomes or improve a biomarker or anything else that, you know, a normal clinician would do. So I think that's what makes us different, is that we're not chasing top line or bottom line revenue. We're actually chasing what is the best outcome for our patients and how do we get that? And so we have really strict guidelines and safety rails. We monitor people routinely. We can monitor wearables. We can monitor lab work. We have our own in-house AI that's helping us link these kind of connections and helping us determine better outcomes for our patients. And then on the compounding front, we're an NABP certified pharmacy. That's a really, really hard designation to get. And we do quality testing on all of our products. We don't bring something to market until we've made sure that it's reproducible, that it meets the grade that we want to meet. Our suppliers are top notch. In fact, the reason we use them is because we know that our supplier goes and inspects the factories where our raw materials come from.
Let's take people through a journey, if that's okay. Let's say someone comes in, they want a GLP-1. What do they go through for you to get an understanding of whether or not you should actually prescribe that?
Yeah, so there's two different routes for that. There's our NIMCOR route, which is our just comprehensive program. And then there's, I just want weight loss. And if you just want weight loss and your BMI is like 25 or 26, we're not going to prescribe that for you if you come in through that pathway. Now, you can come in through the other pathway where we do lab evaluations, talk, see what your goals are. And let's say you've got rheumatoid arthritis or lupus or something like that, or PCOS, and you want to try a GLP to help with the inflammation or maybe some insulin resistance. That's a completely different story. Right? We're not using it for weight loss. We're using it off label for an indication that I think is there. All right. I've used it a lot for people who have insulin resistance, for people who have autoimmune disorders, and now they're being studied in those patient populations like psoriasis and things like that for improvement. So it's the reasoning there is, why do you want it? What's your goal? Is it appropriate? And then how do we safely do this? We don't need to titrate someone who's using it for those other purposes up to the max dose. We find the lowest effective dose, the lowest dosing interval. We have some patients who are using it once every 3 weeks, and that's why they feel good. Their labs look good. And so that's the route that we're going. And so that's the essence of personalized care, right? It's figuring out what that patient's goals are, what their situation is, and designing the best plan for them.
Yeah, and if I'm getting this wrong, please let me know. But that personalized care is, hey, they're coming to you, they're paying a monthly fee. You guys are putting them on these things, but you're keeping an eye on them as they go through. You're making sure that they're actually on in the process. Do I have that right? Like that's kind of what we're talking about, the personalized care.
Yep. So there's monitoring. We monitor their weight. We monitor their labs. We monitor for adverse effects. We monitor what their goals are, if they change. And so that's the whole process of it. If they want to come off the medication, that's fine, or dose reduce. You know, we just kind of leave it up to the patients on where they are on their journey.
And did I notice on the site you are monitoring through wearables?
Mm-hmm.
That's interesting. Can you just talk about that for a second?
Yeah, so there's some pretty interesting stuff happening in the space of wearables and what they're able to detect. We were just on the phone with a company that said they are like 87% concordance with inflammatory markers in IBD patients, inflammatory bowel patients, based upon their wearable algorithm. And I was like, that's pretty crazy. So it's just, we're getting to that age where you can start to see things like, for example, with the GLPs, one of the adverse effects is they can increase heart rate up to maybe about 8 beats a minute or so, maybe more than that. So if we see that happening in the background, we know that, okay, let's check what's going on. Let's see what's going on with this patient. Do we need the dose reduce? Things like that. Another interesting study came out recently that showed that people, when they start GLP, start moving less. And I think that could be one, they think the medication is doing the job for them, so they don't need to exercise as much. Two, I think it could be nutrient deficiencies, especially if they don't change their diet, right? If they're just eating less of junk food, that's a problem, right? And I think the third thing it could be is if people's calorie counts are reduced too drastically, right? So if they're in like automatically going like a 700, 800 calorie deficit right off the bat, they may feel like crud and low energy and fatigued, and that's why they're not moving as much.
The chicken or the egg, the muscle mass is down. Is it down because they're not moving? Is it down because they're not, they're starving themselves? I tell people that, I'm like, you're just starving yourself, so you got to take care of it while you're doing it. So
Exactly.
It's an interesting approach.
And so that helps us kind of triage all of these things and then figure out how to move forward in a way that's sustainable and in the best interest, short-term and long-term of that patient.
I like what you're saying. I'm picturing some kind of monitoring center where, you have all these people on wearables, and what peptides they're taking and everything. You're able to really check and see actually, how that's affecting them. I know I'm making that up in my head, but I'm saying, it sounds like what you're saying is that's where the industry's going.
Mm-hmm. For sure. I mean, we're on calls all the time with some of these tech companies who are doing these kind of things, developing these algorithms, and it's really, really interesting. Yeah. And I'm glad we developed our own in-house AI, so we can take what they're doing and plug it into our patient data and our data sets and figure out how to best use that information for our patients.
Mm-hmm. That's really cool. I want to come back to the peptides for a moment, but I want to just jump over to hormones with you for a minute. So, you have a hormone offering. Can you help people? Because look, first of all, there's so many women out there that are so interested in this, but you actually look at the numbers and there's so many men that are interested in this as well. Can you talk about how you actually assess somebody and how you safely actually put someone on hormones so people can understand like what good looks like?
Yeah, absolutely. So again, good clinicians and good places always ask you, what are your goals? And do a good history, dive into what's going on, do some lab work, screenings. That's always standard of care. You're so right about the women's hormones. I've talked to so many patients who are like, I went to my OB or my PCP who was a woman, and they just told me to suck it up. And 2026, like, we're still hearing this. And I apologize to these women for the failure of my profession, because that's unacceptable, right? To let people suffer like that. And so, for both men and women, we do a standard questionnaire assessment. We use different questionnaires. We use a version of the Green Climacteric Scale for women to check their symptomatology, and we can track that over time. For men, we use a version of the Adams questionnaire, right? And so that can track testosterone deficiency. And so the women, there's a lot of controversy. Well, not controversy. The Menopausal Society says you don't need to check labs. But we check labs for two reasons. One, to see if they're absorbing that dosage form. Because if you're not checking to see if the blood levels go up, then how do you know they're absorbing it? And you can waste a lot of time increasing the dose when they're not absorbing it. And we know that some people just don't absorb things orally. Some people don't absorb things topically, right? Some people don't do well with injections. And so you can kind of triage that and figure that out early. Same thing with the men. So we check their levels, and we basically will go upon symptoms first and foremost. If someone has symptoms, then we'll treat. And no matter really where their levels are, unless, their testosterone's like 900, then you probably don't need any more testosterone, right? We're going to look at other things. But the symptomatology is the biggest driver. And then we see if people improve or not. And if they don't improve, then we take them off that therapy and we try something else.
How many physicians do you have on your team doing this?
So it depends on which arm of the business, right? Some of the more cookie cutter stuff that we've really honed in, and we've trained some other docs to do so, we outsource that to another group that we work with closely. A lot of the women's care and men's care and the specialized peptide stuff is me and a few other docs, right? Because, that space is very small. And so most of the people doing it are in their own businesses. We do have capacity there to grow, but I think it's going to be an area when we start really needing more help, that we turn to people fresh out of residency who are looking for a different program.
All my patients are getting all this, and I'm like, God dang, Dom and I were just talking. I'm a plastic surgeon, and I'm like, I got to take a course on this shit because it's all new since I learned it, So it is the field that for me, that's the hardest part. Dom and I were talking about it this morning. I'm a pretty slow adopter to things that aren't like proven, checked. So that would be the hardest part for me. I think if I was in your shoes, is to like, well, of course you can, look at the labs and see if the symptomatology is getting better, if their labs are going up or down. But without long-term studies, without good data in humans, it's like, shit, am I going to end up hurting somebody? So that's the hardest part for me. And I think that which was a big problem with HRT in women. There was some kind of like bad studies that led people to think that they were hurting them. But it came out after 20 years of giving it, so it's kind of a scary part of the field, right?
You're absolutely correct. So we resisted doing peptides for a long time. Because I was like, I looked at the data, I'm like, there's very little or no human data for these things. And then what happened was there was a rise in the gray market. People getting research-only peptides, getting them from God knows where, from non-reputable compounding pharmacies. And then we waited out and we said, well, I think at this point, people are going to do it no matter what. No matter if their doctor tells them not to or whatever. I think it's more of a public service for us to try to put guardrails on this and just be honest and say, I don't have human research. I don't have outcome studies based upon pharmacology, because I'm a pharmacist too. This is what I think could happen if you're on it long term. And these are why we don't use these agents long term. And so, again, we don't use them for longevity purposes. I think the GLPs actually might be a longevity drug. I think they might do that. I'm like 99.9% sure that they will have a longevity
caloric
benefit.
Restriction is right? Is my understanding that caloric restriction is their number one chance to improve longevity. So it purely does that. Yeah.
Plus some of the anti-inflammatory effects. People smoke less, they drink less, right? So they do less bad stuff. And then also people just seem to feel better from what I've seen when they start taking them. My wife takes them. She has PCOS. A lot of PCOS patients just feel better.
It's a cure-all for that. I see a lot of PCOS people because I do a lot of like face and neck, and they get a little bit of atypical fat distribution. And those people can be, eating, dieting, working out, and they still can't lose weight. So PCOS people, I think, but it's my understanding these are going to be powerful for that population.
Oh yeah, we see it all the time. It changes these women's lives.
Yeah.
I want to go back to the hormones for a second because I thought it was really interesting what you said, and I'm speaking from a perspective of I had my DNA kind of mapped out for medical purposes, and it was really interesting what came back, which was they said, hey, you actually are like an optimal testosterone producer. You produce a lot of testosterone. You also produce a lot of estrogen. Hence, you got like a good head of hair, really clear skin, and your DHT is just squeezed off at the right level because you make so much testosterone that you're still able to really carry muscle and do all that stuff. But they had mentioned that, look, if you want more muscle building and those like that, the easier thing for someone like me to do is to block estrogen off because I'm producing a lot. But they had mentioned something that, you're a large testosterone producer. And of course, as you get older, your testosterone is going to start decreasing. With someone like myself coming in and getting a really high number on testosterone, does that possibly, that's high compared to the average, but I'm normally a very high testosterone producer. So for me, that's low. Am I thinking about that the right way?
So this is interesting because there is some clinician stuff here to tease out. So I'll give you an opposite example first. I've had numerous clients whose testosterone was 150. They're jacked. They have a normal sex life. Their biomarkers, their metabolic markers are all normal, right? What am I treating at that point? I'm treating a number, right? And so what I think is happening to these people is they have really hyper-functioning testosterone receptors or androgen receptors. So their body naturally lowers it as a protective mechanism. So these are the people you're going to mess up by increasing they're going to have all the testosterone related adverse effects. Now, in someone who comes in, their testosterone's high and their estradiol's high, I typically don't block estrogen in men. And the reason for that is it's very important for sex drive. It's very important for metabolic health, for lipid control. Estradiol is one of the few things that we have that decreases lipoprotein A, LP little a. It's important for brain health. So we think that the effects of testosterone on the brain are mostly due to the conversion to estrogen and estradiol in the brain, increasing BDNF and some of those other factors. So unless I think their high estrogen levels are decreasing their testosterone or causing like gynecomastia or mood symptoms, I don't treat it if the number just comes back high. So I also don't look at it always building more muscle mass is the solution. Because I think about, again, what are your goals? If your goals are just, I want to be able to pick up my luggage when I'm 90, okay, cool, that's easy. You don't need like Arnold Schwarzenegger levels of muscle to be able to do that. And then you also have to look at the fact that I balance that out with when you look at people who do too much anabolics, what do they all die from? Heart failure, right? And so you're kind of weighing all this information out and then trying to proceed it as safely as possible without just like looking at labs and saying, okay, let's just juice this as much as we possibly can because we can.
The labs are hard. Like, I mean, you are a level 10 times me, but I did the function health. And I just did like I spent all the money I could spend and I did everything. And then it made all these, it said I was like 5 years younger than I am. I was like, fuck, I'm doing good, you know? And it made all these recommendations. And then I did my 6 months follow-up labs, and I was like, I gained 6 years and 6 months doing what it told me to do. By whatever metric there, I was like so fucking pissed. I was like, and I wasn't drinking. I was like, I haven't red meat. I'm like, this is stupid, dude. I need more meat and more beer, dude. This is like the worst thing I've ever done. So you try to follow them, but we don't, you know, there's so many of them, so many things influence them. Like, I mean, we're taught in school, obviously, you can't treat a scan and you can't treat labs, you know? You got to treat the whole picture. So the labs are tricky. It's easy to like convince yourself or fool yourself. You know, if you well, this is up, but that's down. But when I do this, it's like, fuck, man. That's why I did surgery. I don't want to have to think. I want to see something I can cut it out and be like, look, I did it. I told you. Goodbye. Next.
Right.
You know. So yeah.
Yeah, and I think we're getting to an age where there's too much information and people
honestly.
freak out over one abnormal lab value. And I'm like, all of your other lab values have been fine. There are lab errors. We see them all the time. Were you sick in the last 2 weeks? Oh yeah, I had a cold 2 weeks ago. Okay, that's going to throw off all of these numbers. Did you do a really hard leg day within the last 48 hours? Oh yeah, I tried to deadlift the PR 2 days ago. Of course, all your inflammatory markers are going to be through the roof. Blood sugar is going to be off. There's a science and an art to when you do labs and how you interpret labs as well. And that's where I think that doing stuff like, no offense to all those other just lab companies, that can be detrimental without someone going through and being like, okay, here's what this all actually means. And then I don't believe in any of those longevity clocks whatsoever. Right. Yeah. I just don't do them. I don't prescribe them for patients. I'm just like, listen, let's look at your function, right? How are you getting around throughout the day? Are you able to do the things that you want to do? All right. Is it easy enough for you to get to the gym and build muscle? Are you even going to the gym? Right. So that's the stuff that kind of matters to me. And when I look at longevity, I tell people, I never think about it like extending human life because we just don't know. Over the course of 100 years of a human's life, do you know how many variables that person's going to be exposed to? It's a mind-boggling amount. But if I think about controlling the things I know how to control, preventing disease, that's a big one. Don't get diabetes, don't get hypertension, don't get fatty liver disease, you know, all of these things, and checking for those biomarkers, protecting your brain, you know, so you have the cognitive abilities to do what you want to do as you get older, and then protecting your muscle, building muscle, maintaining strength, maintaining power. So you're able to move about the world how you want to move about the world. That to me is the essence of longevity. And then doing it in a way that you're not miserable. Like you said, like you got these, and you did all this stuff, and that sounds miserable. Man. Yeah.
It
no
sucked.
Red meat, no alcohol.
Like,
yeah.
It sucked.
Yeah, exactly.
I'm back.
Exactly.
I'm back at it. So I'm not going to retest either.
Yeah, exactly. Right. So what's the point if you're miserable? So like, that's the way I look at things, and that's how I approach things.
I like that. I want to get back to, there's been, I think, maybe confusion or misinformation about compounding pharmacies. It seems that compounding pharmacies has somehow gotten like a bad name for some reason. And I just want to get your take on that, like what why, what that actually means. People are always hearing things about salts. They're confused about that. Can you just demystify that for us?
We don't want Eli Lilly to blow up your house or anything during this, okay? So just have your disclaimers. Be smart about it, yeah.
Yeah, don't worry. I still give them plenty of business. So
Okay,
I
good.
think,
Yeah, that's true.
I think we're all right.
They know what they're doing.
Yeah. So, I think it's because of bad actors, right? It's like any other thing that gets popular. Like there are bad actors in the financial sector. There are bad actors in the law sector. There's bad actors in healthcare. And so there were some bad actors who cut corners, who did things they were not supposed to do. And that led to some bad outcomes. But there's, not every compounding pharmacy is the same, just like not every hospital is the same, or not every clinic's the same, or not every grocery store is the same, or fast food restaurant's the same. And so the ones who are really doing that essence of community pharmacy are the ones who are owned by pharmacists. I would never tell a patient to go to a compounding pharmacy that wasn't owned by a pharmacist, because then they're more interested in the business model as opposed to the patients. Our pharmacy is pharmacy owned. It's pharmacist owned. So at the end of the day, we're always going to think about patient safety first. We're always going to make sure that our products are meeting safety standards, that our clean rooms have the right ISO certifications and things like that, that we're doing the right QA. That's when people start cutting those corners, when you can hurt somebody. And that's not only just in compounding pharmacies. Look how many drug recalls are happening all the time now. That's something that nobody's talking about, because we cut the number of FDA inspectors abroad. And so now when these companies aren't being watched, they're cutting corners. And that's how these products are getting adulterated, and you're seeing these recalls. So at the end of the day, when I tell people about a compounding pharmacy, is find one owned by a pharmacist. If you can find one that's NABP certified like we are, that's a really stringent criteria that you have to meet. You have to get inspected for that. That's a really high standard of a compounding pharmacy. And then talk to clinicians who are well-versed in the space. Like they'll know who's getting good patient outcomes and who's not. And so we try to educate patients on this as well, and try to get them and steer them in the right direction, because it is hard if you just don't know the space to know what to look for and what you're getting into.
I noticed on your site there's an offering for I think I got this right, so please correct me if I'm wrong. The GLP-1s, I think there's a compounding offer and then a tirzepatide offer as well. Like those are, can you just help people understand, like, what's the difference between those two things?
Oh, so everything is compounded. So we have a semaglutide and we do tirzepatide. We don't do Retta because it's not legal to compound Retta, because it's not an FDA approved agent at this time, right? So, we're not doing that like some of our other competitors are. But yeah, so another difference with us is, so I don't know if you heard about the B12 scandal with, I think it was semaglutide. What's it, tirzepatide? I can't remember. But whichever drug company, Eli or Novo Nordisk, did a study where they found that the B12 molecule was creating unknown compounds, like compounds that they hadn't seen before when they were compounded together. And so when we did ours, we actually didn't use cobalamin, because we know cobalamin is a very reactive molecule. And so we actually used L-carnitine because it's a less reactive molecule. And so, like, this is the difference between a compounding pharmacist owned by a business and a compounding pharmacist that's owned by a pharmacist. My partner literally was on a board drawing out molar equations, which is in pharmacy, like you're literally looking at the molecules and how they react and like what parts that you need and how you need to make things in order for it to be safe. And so that is essential to who we are. But that's also what makes our products a little bit different, is we didn't just think about what's the easiest way that we can make this. We thought about what's the best way that we can make this from a compound standpoint.
I think for the individuals out there, I think we got a couple things that we got to summarize. One is, you got to make sure, if whoever is prescribing you this and using a compounding pharmacy, you might want to ask a question of, what compounding pharmacy are you using? What certifications do they have? And I think something that we touched on earlier, and please help me with this. With the peptides, it's a big one because getting those raw ingredients and where you're getting those raw ingredients are absolutely critical. I'm guessing the same thing when you're actually compounding a GLP-1 or something like that. You got to make sure you understand what they're compounding that with.
Mm-hmm. Yeah, fair statement. There can be a big difference in raw materials, right? And so that's one of the things that we pride ourselves on, is that we could go with cheaper, we could go with somebody else, but we're not going to do that. We're always going to put patient safety first.
And I want to going back to the testosterone one, I know there's some information out there that if you start taking testosterone, that you can't stop taking testosterone. Is that true?
For some people I've talked to say they see it in about 10% of men where they just don't produce their own again. Now, that typically happens in younger men who are on multiple different anabolics. That's where I usually see that. But my approach is I usually don't put men under 40 on testosterone. And sometimes in between 40 and 50, I may not use directly testosterone. I'll use either clomiphene or Pregnal, and because they work to actually increase the body's own testosterone production. So in those younger men who I think may still have what we call testicular reserve, that can kind of jumpstart that. I'll also use those agents in men who are coming off of anabolics, who don't want to be on testosterone anymore, to see if I can jumpstart their testes producing testosterone again. And then, you have to be careful with the dosing. I actually, when I was still doing some part-time hospital work, I saw a guy who was 30 with a stroke because he went to one of those TRT clinics. They didn't check labs afterwards. His hemoglobin and hematocrit, so hemoglobin is part of red blood cells will carry oxygen. Hematocrit is part of your blood that's like stuff. They were undetectably high. So this guy's blood was so thick that he had a stroke from his testosterone therapy that someone was prescribing inappropriately. So that's what you kind of have to look at is how are people talking about these things? Are they monitoring you? Are they checking labs? I mean, the American Urology Society or Association, like, not that I'm a big guideline guy, but that can, at least you can see what is the standard of care, right? If you go look at the testosterone guidelines, am I at least getting monitored by the standard of care? Are they checking a PSA? Are they checking my blood counts? Did they check a prolactin level if I'm a young guy? I've diagnosed multiple young men with tumors in the pituitaries because they had low T and no one checked their prolactin. They just gave them testosterone. So that gives you a sense of, is this person at least monitoring me in a way that the consensus says I should be monitored?
Dom, we had talked to, which I'm interested in. It's a little bit switching the gears. So if you have something you want to hit on that point.
Yeah,
Dom,
I just want to ask one question is I noticed, and Richard, I have this wrong, please help me also, but it seems like for Nimbus, did you guys go for TRT before HRT, like HRT's coming for Nimbus, or do I have that wrong?
No, so we're doing both. We just haven't really mass advertised our women's side yet because women's care is a lot more complex, right? And there's a lot more moving parts. And so
women are complex, man. Women are just more complex overall. We all know.
Ben, dude, don't get us canceled. Dude, you just not get us canceled. What the fuck are you doing?
I mean, they're just like fuck, But okay, let me switch gears. So
Yeah,
you were, so I sold out. I'm cash only. I don't help people anymore. One of my kids said, "Do you still help people or you just make them pretty?" I'm like, "No, I just make them pretty. I don't fucking help anybody." But I think I'd be interested to hear your side from because now you're a business owner, or right, as far as I understand it, and you're still, it seemed like you're trying to help people and be a good clinician. I mean, I'm a good clinician. I help people. Don't get me wrong. I do it safe, all of that. But there is like a delicate balance from making money, giving good care, following the guidelines, even if we think the guidelines are outdated or misconstrued or tainted somehow. I think when you decide to do cosmetic plastic surgery, you kind of own that, and it's easy. People know that I'm trying to make money. In your field, it's a little bit harder because it's really so much more tied to their personal health than solely just getting jacked, like you said. So how have you found that balance?
Yeah, it's interesting. So with Nimbus, no one's really said anything or balked at the price or anything like that. We try to be transparent, and because we are vertically integrated, we can offer people things at a lower price and still have good margins for ourselves. In my private business that So I have my own clinic, a telemedicine clinic, and it's kind of my testing ground for Nimbus. Like I test things with patients, I test out new things, and then I bring those workflows and then put them in Nimbus. My private practice, people are like, you need to charge more.
Yeah,
right?
concierge medicine's a thing.
Yeah. Yeah, they're like, you're not charging enough. And I'm like, it's okay. I'm charging this because this is why I'm doing this. Like I'm doing this to figure things out and then bring this to my other business. And like, I'm not a money motivated guy. I'm just not. There's a lot of other things I could be doing to make a lot more money. But, you know, I have a good life. Me and my wife, we live in a good life. So I really focus on delivering the most value to people. And I've always said to myself, if you deliver value to people, you will make a lot of money.
It's true. It's good though.
That is actually true. If people can actually see the value, then you actually are in a position. I want to ask a business question, but I actually want to ask one more like really important question. Like I think your approach is really great in the sense of it seems that you are not just trying to address whatever the person's walking in the door with. And I think that's probably the essence of functional medicine, integrative medicine. Is that a fair statement?
Oh, yeah. Yeah. So people come to us as one thing, and then the way we do our assessments and our labs, I end up often treating stuff that they didn't come to us for. But that's what we found out. And it's like, okay, you came to us for this and you thought it was this, but I think this is actually your problem. And if we fix this, then I think this will get better. So I brought that whole holistic approach to Nimbus, and that was something that was very important to me, that we don't just be another cookie cutter telemedicine company.
Yeah, I like that. I think that's good. Because I wouldn't tell you I liked it if I didn't, but I myself experienced it more on a functional medicine level of saying, okay, well, this is my issue. And it's like, okay, well, let's get all your labs and check everything. And it's like, no, actually your issue is this. And I've had that kind of epiphany for myself. And by the way, easily changed with a diet change and whatnot. But I think that's pretty powerful stuff. You know, you spend all this time becoming a pharmacist, a doctor, all these kind of different things. Like, how are you coping or feeling on being a business person? Like, it seems like, you know, you got stuff going on. Are you liking that? Are you enjoying it? Do you find it challenging?
I love it because, as you guys know, entrepreneurship, if you go in it to make money, you're probably not going to do well. If you go in it for the freedom that it brings you, and you, like you said earlier, you really want to bring value to people that people can see and feel, you will do very well, right? And so for me, when I was in full-time practice, working at a large group, I wasn't able to do all my other interests, right? It was like I had 1,500 patients. I was seeing 30 patients a day. I was on call for my patients every weekend, and I had to work 1 week in a month in the hospital. I had no life. And at the time, you know, I say I was only making like $250,000 a year, but then, you know, my colleagues are making double, triple that and working less. And I was like, this doesn't make any sense. Like, this is not sustainable for me. And so I actually got my MBA, and I thought I wanted to do healthcare administration when I was getting the MBA. And in the classroom, I got the entrepreneurial bug. And so that's when I started to put feelers out there about what do I want to do. And so I started doing a little bit of functional medicine, and I kind of paired that back into more lifestyle medicine and preventative care and metabolic health. I think those are, I would say, are the things I specialize in now. And then I started consulting. So at one point I had 15 consulting clients. I only have 2 now just because I got busier with Nimbus, but building health tech companies, I really like that. And then consulting with supplement companies, I really like that. And so formulating supplements, talking about the pharmacology of different agents, that was fun. I started doing professional speaking. So now I travel all around the country talking about lifestyle medicine and preventative health and how to read and evaluate labs and biomarkers and things like that. So now I'm able to do all of these different things. And that's what entrepreneurship has really brought for me, is that I'm able to chase what I'm passionate about in multiple different areas of healthcare.
Yeah, that's cool.
So I want to just press in on a couple of those things. I think I'm going to summarize is that you're enjoying providing value to people and bringing value to people. Yeah, it does. If you are truly bringing value to people, yeah, you're going to have a viable business. You brought another point up, though, that I think a lot of people don't talk about and maybe is not as fashionable to talk about is the freedom. I think a lot of times when we think about entrepreneurship, we think about busting our ass, working like crazy, doing everything that we got to do. And I think what you just said there, I think is probably a really important piece of entrepreneurship that a lot of people maybe pass off, which is that it's freedom. And when you feel free, you tend to be more interested. You tend to actually work harder because you don't feel like there's an obligation. It's more like, no, I'm actually enjoying this because I'm actually doing the things that I feel like I want to do. So I think that freedom part is so important because I think it gets missed like quite a bit. So I didn't want to let that go by because I think it's absolutely critical. And if I can bring just one more point up too, actually, I thought about this last night. I had this crazy epiphany last night where I realized when I was younger, I was very uncomfortable with being uncomfortable. And I would shy away from kind of doing the things that I sometimes know I needed to do because I didn't want to be uncomfortable. And for myself, being a serial entrepreneur, I've absolutely gotten very comfortable with being uncomfortable. And in fact, I probably feel like I'm not progressing if I'm actually comfortable. But I would tell you, I was a whore for comfort when I was younger. And that freedom that comes with entrepreneurship, even though there's a lot of burden of doing the work and everything like that, what you're really appreciating and enjoying is the fact that you're kind of living in a little bit of chaos of building something and making something great and making it fantastic, but there's a freedom in that at the same time. So I just want to identify what you said because I thought that was really critical.
It is, and there's always growth. Like I'm always learning. This past year, I was working with a biomedical engineering PhD, and we're doing prompt engineering on our AI platform. And I'm learning about Claude and learning about how that's working and how that's pulling our data. And I'm sitting there talking to a computer about like why I prescribed certain things or why I did certain things or why I interpreted these labs a certain way. And it was super weird because I never thought I'd be sitting there doing that. And but that's now part of my job. And now where I sit at Nimbus, I'm kind of at the intersection. Yes, I'm our clinical lead, but I also work with our dev team on our software. I work with our ops team at the pharmacy. I work with our customer support team. I work with our leadership team. So now it's like I'm sitting here at all these different intersections of the business. And that to me is really, really fun because I'm learning so much.
Yeah, that's good. I want to get into our rapid fire and close, but I want to ask one major question that I forgot because I think it's just so important. We know all about GLP-1s and there's a lot of information about that, but there's all these other peptides that are out there. And how do we know what's safe? How do we know what's legal? How do we discern from one thing to another? Like, what are your thoughts on that?
So number one, don't get research-only peptides. That's like the biggest thing I think I can tell you to do. And the reason for that is when they're made, they don't have to go to the same standards for human consumption. So they don't have to remove certain toxins and waste products and things like that we have to do in our pharmacy. That's the biggest thing. The second thing is if someone tells you take these peptides for longevity, run. Because there's no medication out there that any reputable doc is going to tell you take for longevity. Why would these peptides be suddenly any different? So it's all about use case. It's all about, a lot of them are for, I think, short-term use. And then if they're not monitoring labs or talking to you about like, hey, we just don't know safety profiles for most of these things. We don't know the long-term effects. If they're just selling it to you like it's rainbow, like a pot of gold under the rainbow and there's no possible adverse effects, run. And that's how we talk to patients about these things.
That was great.
Yeah,
Thank you for
advice,
that.
yeah.
So these are our rapid fire questions. There's 5 questions here. We ask them, but what do you think in your industry, what do you think is absolute magic? Like you're like, this works. It's a thing. It's fantastic. Like this is real. I love it. What would you say is that?
If I can get people to buy in, starting to do breath work.
Dom loves that
I
shit.
respect that.
I've
I
tried
love
to do it.
that.
I can't do it, man.
Yes, you
can't do
can,
it.
Ben. I sent
can't
you
do
the
it.
dude.
No,
I sent you the
I know.
link
It's like
also.
I did it for like 3
No,
days.
but I
and then
sent
quit.
that. Dude, it's guided. It's 10 minutes.
I know. It's like
man.
I know.
Yeah.
It's a long time. I'm a busy guy.
Yeah, but why can't you do it? It's 10
I can't
minutes. The
fucking do it,
dude's
yeah.
telling you to breathe in. He's telling you to breathe out. He's telling you to
I know,
hold your
man.
breath.
I'm like, this is taking too long. I listen at 2 times speed. I'm like, come on, hurry up, man.
Jesus Christ, Ben. Like,
Yeah.
all right. We'll take that offline.
We need to go drop Ben in the woods for like a couple
Yeah.
days so he can just
Yeah.
go chill
Could you
out.
imagine?
I know.
Yeah.
So imagine if I wasn't drinking or eating red meat. How about fucking 6 months? That's
Richard,
probably
but
why I gave 6 years.
I appreciate the breath work. We had a guy on, actually a buddy of mine who is really focused on this. A lot of good science coming around about that. Fair?
Yeah, I think it's just people just need to disconnect. I think that's the number one thing. The number two thing I would say in that regard that I think is mind blowing: put this away. Put social media away. Take breaks from social media. Take breaks from your cell phone. Reconnect with the world. I think those are two things that can make huge differences on how people feel.
I love that. I think people are going to find that as an unexpected answer from you, and I think you're absolutely right. What in your industry is absolute bullshit?
Insurance companies.
Okay.
Yeah.
I didn't think that was going to be the answer.
I figured that one out
That's
before
okay.
you, Richard. I figured that one out a long time ago, so that's why I quit them.
Scam artists. Absolute scam artists.
Yeah. And sorry, could you give us just a touch more color on that?
What was it last quarter? I think United made like $4.6 billion or something like that. Something crazy like that. And they denied like 32% of all claims. They take your money and then deny your care. And then they increase your premiums. Right? The business model is this: they either increase your premiums to make more money or don't pay for stuff.
Well, you can't argue with that. It's a brilliant business model. They got that. They got that down. You got to give them credit where credit is due.
I mean, Ben, it's like people paying you to do their job and you're just not doing it.
Yeah, and then they do it, and then I do their
You see,
surgery, and
Richard,
I'm like,
Ben was considering it. He was like, wait a second.
no, and then if they do it, I say, hey, you paid for it, but by the way, every month you got to give me $100 extra after that, after they paid for it. You know, like
Right.
that's fucked
Right.
up. Yeah.
Yep.
That's right. Richard, where do you think the business or the industry is 5 years from now?
What I'm hoping is we have AI assisted clinicians that removes a lot of that admin work, but also helps us connect the dots on people's data. So what I'm hoping this does is that right now the EHRs own your data. I want people to own their data. So now when they come to me, like there's a flash drive and it plugs into my computer, and now I have all of their records, everything that's happened to them, all of their labs, and I can run that through my AI to help me piece together where this patient's been and where they think they're going.
We love this question. And I know you said, hey, not that concerned about the money, but if money was not an issue at all, you can do anything you want, what would you be doing?
Teaching.
Teaching.
Yeah, I love educating. So the problem with being a physician, especially in what I do, is like people will come to you, but you have no idea where they are on their action curve. Like, are they in pre-contemplation, contemplation? Are they serious or not? But when you're working with students, especially college students, they're paying to be there. They're there because they want to be there. If they didn't want to be there, they wouldn't be there. And so it's really cool to work with those young minds and help them grow and become the clinicians that they want to be. I find that to be so fun.
That's really cool. Last thing, what do you want to be known for? What's on your tombstone?
I tell people this all the time. It's like, if I died tomorrow, what I want people to say about me is Richard tried to make a difference. That would be, I'd be a happy man if I said I tried to make a difference. And if one person just came and said, my life was better because you were in it.
Yeah. I believe that, actually. I believe that. I appreciate it. That is Dr. Richard Harris, folks. Dr. Richard Harris, you can find him through private practice. You can find him at Nimbus Healthcare. Richard, we want to really appreciate, this was fun. And I think it was incredibly educational for all of us. And yeah, we really appreciate it. So thank you so much for being on the pod.
Yeah, thanks you guys for having me.
Keep it
I had
up.
a good time.
It's important right now, too, to have honest, good people putting good information out there. I mean, that's the thing about the social media world. It's all of our fields, but I think when the fields are breaking into when they're having a moment is when it's easy there's so much information out there. Like 75% of it is just complete crap. So,
Yep.
You got to get your word out. You got to be louder, I would say.
Yep. I'm working on it.
Good. Yeah. Good job.
Great. Okay. Thank you, Richard.
All right. Thank you guys. Y'all have a
Okay,
good one.
man. Nice to meet you.